session sponsored by AstraZeneca, a case-based panel discussion, optimal management of stage 3 NSCLC, for which I would like to invite Dr. Sushant Mittal, Senior Consultant Medical Oncologist, Action Cancer Center, New Delhi. And I will like to introduce the panelist. Dr. Ramakant Deshpande sir, he is a Surgical Oncologist Executive Chairman, Asia Cancer Institute. Dr. P.K. Das, a Senior Consultant Medical Oncology, Apollo Cancer Institute, New Delhi. Dr. Anil Tabdewal, Assistant Professor, Radiation Oncology, Tata Medical Center, Mumbai. Dr. Sridhar P.S., Senior Consultant, Radiation Oncology, SCG, Bangalore. Dr. Gagan Saini, Director, Radiation Oncology, Max Super Specialty Hospital, Delhi NCR. And Dr. Ashish Joshi, Consultant Medical Oncologist, Nanavati Super Specialty Hospital and Director, Mumbai Oncology Care. Over to Dr. Sushant Mittal.
Good morning everyone, and I hope the Sunday academic feast is good for everyone. Dr. Gagan seems to be jogging or walking in a park. That's great. So can I have the slides, please?
Dr. Sushant, Dr. Das is not there.
Okay, fine. No issues. So I'll start with the case presentation. In March 2018, 52-year-old gentleman presented with cough, weight loss, and X-ray had these lesions. Next slide. And the CT scan was suggestive of a large heterogeneous enhancing lesion with necrotic component involving the apico-posterior segment of the left upper lobe. Along with that, few sub-centimeter and enlarged mediastinal lymph nodes were likely representing metastatic involvement. A small nodule is seen along the right upper lobe, which may represent a post-infectious or metastatic nodule. So, as expected, we did a PET scan. Next slide. And it showed a mass in the upper lesion, 7.6 versus 7.5 into 8.3 in the left upper lobe, abutting the costal and the mediastinal pleura in the apical segment. And the mass is abutting the arch of aorta and encasing the left upper lobe bronchus with mediastinal lymph nodes on the right side, likely a neoplastic etiology. So, the patient first goes to a surgical oncologist. So, Dr. Deshpande, sir, how would you like to go ahead with this, sir? So, you're muted, sir.
Hello, this is a 3B stage, so obviously not a primary surgical candidate unless and until he's part of a clinical trial. So I would, in the joint clinic, I would say that I will hand him over to the medical oncologist and the radiation oncologist.
Thank you, sir. So Dr. Ashish.
Yeah. So I think, as sir has very rightly mentioned, this is a stage 3B disease. We have got a contralateral mediastinal nodes. So this patient will definitely go in for a concurrent chemoradiation as a standard of care.
Great. So next slide, please. We did the biopsy and it was poorly differentiated adenocarcinoma. IHC was suggestive of this only. And so the diagnosis was T4N3M0, stage 3C, with the FDG avid contralateral mediastinal lymph nodes. So Dr. Gagan, sir, what would you like to have next information?
Okay, I think all the information is complete. I would just maybe if I were if I were there, I would probably examine the PET CT films more closely, as in just trying to see if any of those mediastinal lymph nodes require any EBUS or some sort of a histopathological confirmation before we label it, because not just because of to change the decision. I guess it still stays T4 and not really taking it away from chemoradiotherapy, but for a radiation oncologist, sometimes taking contralateral nodes means increasing pneumonitis. So I would just do that. So since you were asking what more information I would like, I would probably examine them. But this is an academic discussion. So assuming that all these are what they are, we would start planning the patient for radical radiation therapy to a dose of 60 gray by making the appropriate cast and doing appropriate 4-dimensional CT scans, etc.
If I may interject here, though I said that this is not primarily a surgical case, I would still, in the appropriateness of the investigation, an EBUS would be in order before you take the final call.
Sir.
So, Dr. Ashish, would you like to do an EBUS in your practice? Do you do for such patients?
So typically, if the nodes are quite conspicuous and FDG have it, I think for academic discussion, it is often should be prescribed. But technically, I think these patients go in for a concurrent chemoradiation upfront.
Okay, great.
No, I wouldn't disagree. I wouldn't disagree, sir. The only reason why I was insisting on having this EBUS or whatever is appropriate for the lymph nodes and in terms of safety was the fact that sometimes the contralateral nodes, they increase the volume so much for radiation therapy that it just increases the possibility of pneumonitis manyfold. So that was just a thought. So that was it. But yeah, we should start planning for concurrent chemoradiotherapy.
So, Dr. Shridhar.
Yeah, I agree with all the panelists. Probably one thing extra I will do is I would like to make sure that the MRI brain is also done to make sure that there is no mets in the brain. So that is one thing. Otherwise, it's a clear cut for concurrent CTRT. Yeah. So the elective the mediastinal nodes are not irradiated. So I won't be worried about because it's only the involved nodal RT what I am going to give even to the contralateral node. So I'm not be very keen about if there's a PET of it, I would like to go ahead and irradiate those areas only. No other nodes, only PET involved areas I would like to include.
So, do you routinely do MRI brain?
Yeah, I do.
In non-small cell also you do routinely?
Yeah, all NSCLCs, even in the stage 1, especially when I'm considering for an SBRT setting kind of a things, even in this case, as in the second phase, if I wanted to boost these areas, my patients with lung cancers will have a MRI brain screening.
So, Dr. Anil.
Yeah, hi, Sushant.
Hi. So, how would you now? Next slide, please. So, what's the intent for this treatment in this case, and how would you like to achieve?
So, the intent of the treatment is still curative, and as far as how would you achieve the same is as the standard of care currently worldwide is the current chemoradiation therapy followed by durvalumab. As per the Pacific trial, and as the previous speaker has already shown that the median progression-free survival in real-world practice has actually improved from the Pacific trial itself. So we should see a median progression-free survival improvement and hopefully a 5-year overall survival rate of not less than 40%. So approximately 43% was the 5-year overall survival.
Yeah, we'll come to that. Now, what I want to ask is you are in Tata and Dr. Gagan is in private practice. So, how would you like to go about? You would like to go sequentially? You would like to go concurrently, looking at the burden of patients you have in Tata and how availability of the machine for the patient?
See, as far as the fitness part of the patient is concerned, we would like to do pulmonary function test as well as the effort tolerance. We'll ask the effort tolerance of the patient. If the pulmonary function test is good and the patient is good without any comorbidities and does not cause any significant toxicity with concurrent chemoradiation therapy, the patient will go for standard for concurrent chemoradiation therapy.
Great. So next slide.
I don't know, Dr. Sushant. I just wanted to make a point that each and every meta-analysis and including this one real-world data which was just presented, everything has always shown that concurrent chemoradiotherapy is so much superior over sequential. It's always been statistically significant in meta-analysis, systematic reviews. So giving a chemotherapy straight upfront to a stage 3B or a 3C patient generally is counterproductive to the patient and does not help unless, of course, it's decreasing the tumor size to such a level that some pneumonitis is prevented. Now, this is an upper lobe lesion, so I am not worried about that part. So the parenchymal pneumonitis, because geometrically, from whatever that one slide I could see, we can do safe radiation to the parenchyma. So we don't need to reduce the size. So I would go for concurrent chemoradiotherapy for this patient.
Dr. Ashish, how commonly do you do NACT followed? How commonly do you do sequential or concurrent?
Yeah.
What's the take?
So I think jury is quite clear here that the concurrent is superior to sequential. I think it's been proven beyond doubt. But what actually happens in our clinic sometimes is the bulk of the tumor, we refer the patient to a radiation oncologist, and probably we get a feedback that the bulk of the tumor is so big that the radiation volume is very high. And then probably there is a request then to, give some sort of neoadjuvant chemotherapy to downsize the tumor and then go in for a concurrent chemoradiation. So this practically happens. But typically, if you ask if radiation oncologist is comfortable, the baseline lung functions are good, then concurrent chemoradiation could be the first option for these patients. But often, for a few indications, there has been a request to start neoadjuvant chemotherapy, and that is the time when we do it.
So, Dr. Shridhar, so if the patient performance status was 3 and he has gone to a government hospital where the disease burden is low, very high, and the radiation appointments are not available, would you still request the radiation oncologist to please somehow arrange an appointment for this patient, or you will start with the neoadjuvant?
See, that's a very tricky situation. Like, it all depends on where the patient lands and what is the comfort level. The answering some of the questions. There's one question that mediastinal nodes comes negative.
You're muted.
Sorry. So the mediastinal node comes negative. We won't, in a mediastinoscopy, we don't want to include that in the radiation field. That's very clear. If you are not at the mediastinoscopy and it comes, if the PET uptake area will take it as positive. That is number one. Number two, to answer the question, the neoadjuvant CT, as Dr. Gagan says, so stage 3B with a concurrent CTRT and followed by the further management with IO may be more appropriate rather than going for the neoadjuvant CT as such. Then the scenario of a logistics where you are talking about there is a workload is more and all. So that time, whatever is appropriate at that point of time, adding the neoadjuvant may not be a bad idea, rather than not treating the patient.
Dr. Kannan here, can I add up a few points?
Yes, sir, please.
The practical experience, I perfectly agree with Dr. Ashish Joshi, who brought up a point. Recently, we had 2 cases wherein we told the patient appears very large, we have to do the DVH, we will do it. And we did the DVH as a part of the planning. We found it extremely high, V20, V5. A lot of this dose volume struggles recalled. We have to cancel it. We have sent the patient for NACT. So the point which Ashish Joshi made, we have all the facilities. We don't have a waiting time, nothing of that sort. But when we expect that the lung toxicity or cardiac toxicity may be higher than the expected, we do and we have done cases NACT followed by concurrent CTRT. Thank you.
No confusion.
So next slide. So that's what I was trying to bring in, that a multidisciplinary team discussion is very important for the survival of the patient in stage 3 lung cancer. It has been proven in this study +1, which shows that the median survival of the patients who were treated after MDT discussion was 41 months versus without MDT was 25. So such a significant improvement in the overall survival has been there when so many brains work together for the betterment of the patient. So the takeaway message is MDT approach gives the best outcome for the patient of stage 3 NSCLC. And I think everybody would agree to that. So next slide. So now stage 3 is a very heterogeneous disease, and I'm sure this slide is small, but we all know that we have different variety of stage 3. So what's the difference in the management of N1 versus N2? So I'll start with Anil, Dr. Anil.
So if you are asking about stage 3 and 1, then it's a different thing. First of all, the primary tumor resectability has to be determined. If the primary tumor is resectable and the thoracic surgeon feels that the patient is operable, then we should go ahead with the surgery. There is no doubt about that. The only area where there is very heterogeneity as well as controversy is the N2. So generally and largely, patient with a single station N2 can also have a good surgical outcome as well as with the CTRT. If you remember the paper by Kathy Elben et al., so which was published in 2009, so it also showed that in a subset analysis, the patient who underwent lobectomy with a single station N2 has got a better overall survival as compared to pneumonectomy as well as multi-station. So if it's a, then probably yes, the neoadjuvant chemotherapy followed by surgical assessment is required. If the patient is having multi-station N2, then upfront concurrent chemoradiation therapy will be good enough.
So next slide. And Deshpande sir, how would you go ahead with N1 disease, stage 3 N1 disease, sir? Sir, are you there?
Sir is muted.
Hello. Sorry. Hello.
Yes, sir. Yes, sir. We can hear you, sir.
See, if it's a preliminarily diagnosed T3N1, then it's a primary surgery. If it's a N2, still.
Sir, you're muted, sir. Sir, you're muted, sir. Yes, sir.
Hello. Can you hear me now?
Yeah, yes, sir. We can hear you now.
Yeah. If it's T3N1, then it is primary surgery. And if it is T3N2 single station, then it will be primary surgery. If it's multi-station, then it will go in for chemoradiation.
Thank you, sir. Next slide, please. Next slide. So next slide. So to continue with the case, this patient received neoadjuvant chemotherapy with paclitaxel. He had some reactions with the paclitaxel, so it was changed over to nab-paclitaxel, and he completed the treatment, and the PET scan showed a partial response to the therapy. Next slide.
Excuse me, Dr. Sushant, you have next 5 minutes to finish.
Yes, sir. That's why I'm going through it. So now the patient had a partial response, and he was given concurrent CTRT, and he tolerated the treatment well. He completed the treatment in November 2018. So the doses are adequate, radiation doses are adequate, Dr. Gagan, Dr. Anil?
Yeah, they look adequate. They look adequate. We should actually try to push in as much dose as possible without causing pneumonitis. Although the Astro recommendations kind of, put a ceiling to 60 gray, but because, there has been some meta-analysis and other things which show that it does not matter. But for an individual case, if we can push in more dose, like even I would have done for this case, because it was geometrically located in a location where we can push in more dose. This is a good dose.
So next slide. Next slide. We have discussed this. Concurrent radiation is better than sequential. Next slide. Next slide. So even after giving neoadjuvant and giving this doses, patient developed radiation pneumonitis. So Dr. Ashish,
Yeah.
would you like to add Durva right now, or you'll wait for this radiation pneumonitis to settle down?
So typically, I would want the radiation pneumonitis to settle down, because I think in the durvalumab situation, and that is the only a point which comes in our way of giving adequate treatment. The incidence of pneumonitis is upwards of 16.3%, which is quite high. So in this case, I would want to wait for pneumonitis to settle and then start on durvalumab. Otherwise, we would want to start it early.
So next slide. So still now, before Durva, we didn't have any consolidation chemo radiation for the post CTRT patient, and patients do keep asking us what should be done, doc, to prevent the disease from coming back. So now we have the answer of Durva. Next slide. So this was the study, we all know about it. Dr. Sridhar, how often are you able to enroll the patients in Durva after the radiation is finished? You within 6 weeks or after 6 weeks? What's your experience?
Yeah, Dr. Kannan already asked that question. How practically the patients are affording, and how
I'm not talking about the affordability. I'm talking, is it possible for you within 6 weeks you're able to enroll the patient to take up for the Durva?
Yeah, so 6 weeks is between 4 to 6 weeks is the time what I like to do it. See, among the radiation oncologists, the radiation pneumonitis is one of the things which is always a problem. it all depends on how much margins you are taken for that particular patient. If your margins are more than 1 centimeters and the low dose is like we talk about B20 and other things, so that is the one which is causing to cause a more radiation pneumonitis. So if you are looking for the starting the immunotherapy as such, probably I would like to reduce the doses and keep my low dose area also the tight distribution. And 60 to 60, minimum 66 gray is definitely one. There is something called a simultaneous integrated boost. With that, I would like to give more insight than radiation dose to the periphery so that pneumonitis decreases. And 6 weeks is the time I would like to introduce the immunotherapy at any given part of it.
Great. Next slide. Next slide. Next slide. We have discussed pneumonitis. So this we know Durva is indicated and approved in India as a maintenance therapy. And next slide. Dr. Anil, I would like to ask you, when do you counsel the patient for giving durvalumab in your practice? At the beginning of the treatment, or when you see the response and patient has achieved some response, then you counsel? Next slide. Next slide. Yeah.
Yeah. So if I can speak on the behalf of my medical oncologist, we counsel the patient upfront. So without looking at the response, obviously we will reassess the patient after the completion of CTRT, how the patient is tolerating and how the patient has had any toxicities or not. But we counsel the patient upfront. We look for the affordability. We look for the health insurance if the patient is having anything, so that the patient can be prepared for the addition of durvalumab as a maintenance therapy.
Dr. Ashish?
Yeah, I completely agree. I think counseling this upfront is very, very critical. Otherwise, if you get the story in between the arc of the treatment, then even if the patient is probably affording, he will probably not go for it. Correct. So I think counseling upfront is very, very critical, that this is an option which is there on the horizon. And if the scientific indications permit, we would want to include that in your clinical, in the clinical scenario.
Especially when I totally agree with that. The roadmap has to be done upfront. That makes a lot of difference, because like depending on the radiation pneumonitis, and that if you start telling, it's always a confusion. And especially when a neoadjuvant setting like this, so it's always a confusion that you want to stop at 3 cycles or 6 cycles to complete. So that is another reason that I always prefer to do CTRT followed by maintenance durvalumab or other things upfront, rather than wait and watch. Like neoadjuvant, when we give neoadjuvant, there is always an issue about this, especially.
Thank you. Next slide, please. Next slide. Next. So this has shown a PFS benefit and an OS benefit. Both is there, and that's why this discussion is happening. Next slide. And take me to the last slide, take home message. Yes. So to conclude is that MDT approach gives the best outcome for patient with stage 3 NSCLC. CCRT gives a better outcome than RT alone or CT alone. Concurrently is better. It is the first and only approved immunotherapy to demonstrate a 5-year overall survival and PFS benefit, even at the end of 43 months. That's remarkable. And consolidation chemotherapy does not improve outcome. Durva should be considered, and it improves outcome irrespective of the PD-L1 status. And this EGFR line, I like to ask Dr. Ashish, how often do you get or do you do EGFR or NGS testing in stage 3 lung cancer? That's the last question, and then we are over.
So typically we are not doing, sir, at this point of time, EGFR and NGS, in the sense we even if we do it, we do not have immediate clinical implications. But large number of these patients, even if with Durva, are eventually going to become a metastatic disease. So that's where I think we will have a role of EGFR and PDL1 to go in. But now with this, currently I think just gefitinib data was produced. There is a concurrent pembro study which is going on. So I'm sure I think this clinical practice would eventually make a change. But as of now, I think if you look at typically at clinical decision making, that would not change my treatment. But I tend to do it for stage 3B patients in my clinical practice, because a lot of them then eventually become a metastatic disease, and that's where probably you would have an option.
So I also feel that EGFR status should be done because the driving mutation, if it is there, then giving Durva in such patients, I don't know, it may not be helpful. Although we still have that LAURA study, it's still going on, in which we are giving osimertinib in EGFR positive patients. So that will answer the question. This study also had about 6% of patients who were EGFR positive. So with this, thank you all for having coming over on this Sunday morning. Thank you so much for an esteemed panel, and back to the organizers.
Yeah.
Thank you.
Yeah.
Yes,
Thank you,
thank you,
Dr.
Sushant.
Sushant.
Yeah.
Thank you very much.